Hello everyone, this presentation is about the bottom line of pay for performance, a review of its effects on rural inequalities. I am Judith Olivares Trevino, a family nurse practitioner and a DMP student at the University of Health Science Center, Houston. Prior to the Pay for Performance initiative, providers and hospitals were paid through a fee-for-service model, a payment system that obtained payment directly for services rendered and not necessarily for quality of care provided. The issue was that cost of healthcare was increasing and the quality of care was not. The problem at hand was how to find a payment system that would ensure increased quality of care to populations. Through the initiation of the Affordable Care Act, the Centers of Medicare Services launched an incentive for pay for performance, which attached a financial incentive for providing value-based care to individuals. This included providers and healthcare institutions such as hospitals. This appealed to all stakeholders. CMS set forth a payment schedule for reimbursement based on standardized assessment of quality scores. These are called quality of care metrics. Time no longer equaled payment, and now quality value-based care would be the new target for providing healthcare services in urban and rural settings. A literature review by Chen et al. Found that cost of care for those with ethnic disparities was higher despite the initiation of incentive programs. They also found that gaps in disparities widened amongst minorities and whites. The quality of care metrics designed by CMS do not account for disparities and are not all inclusive of social determinants, especially for healthcare institutions in rural settings, who serve a large population of uninsured and underinsured individuals. Healthcare facilities in rural settings were tasked with trying to meet metrics that did not take into account spatial inequalities of care. Thus, they still had to meet the same quality care metrics as those facilities with decreased socioeconomic burden. While incentives to meet quality care metrics could drive the improvement in healthcare services, it too can decrease the quality of care provided to populations in rural settings due to decreased reimbursement. This inadvertently hinders access to quality health care. Blanket reimbursement for quality outcomes is not adequate for remote healthcare institutions who service a greater number of uninsured individuals. Outcome measures are not suitable quality care metrics and require adjustment for the populations being served. Bridging the urban-rural gap in healthcare of publicly provided goods is essential to providing increased quality of care. Castellino et al. Found that death rates for cabbage increased the gap between whites and blacks, and the quality scores were suboptimal due to inadequate adjustment for rural and socioeconomic characteristics. Decreased reimbursement for rural facilities can lead to decreased access to acute care services in rural settings. Hospital closures and instability increase healthcare disparities, especially in areas with lower socioeconomic disadvantages. As per Goldman and Dudley, approximately 20% of U.S. residents reside in rural communities. These populations are usually older, less educated, with higher rates of uninsured, and suffer greater comorbidities from chronic conditions. Yet, these populations continue to have increased healthcare challenges due to disparity. The lack of adequate reimbursement can increase distress and access to care. As per a review of hospital survival in rural markets by Carroll et al., there was a closure of approximately 140 rural hospitals between 2010 and 2021, leading to increased mortality. Carroll et al. Report that lower volume affects revenue and makes it complicated for hospitals to cover costs of providing services at a fixed cost. Rural areas have a greater portion of Medicare and Medicaid participants that are reimbursed at a lower rate than commercial insurers. Breaking the barriers and addressing inequalities and disparities in pay for performance programs can lead to improved quality outcomes. Making adjustment for rural quality care metrics can bridge the gap between urban and rural healthcare services. Government continues to seek a solution to reducing healthcare debt burden. Pay for performance and value-based care has proven to improve overall healthcare costs. However, blanket reimbursement and healthcare quality metrics need adjustment to meet the needs of rural communities. High-burden hospitals have lower adherence to quality measures due to socioeconomic disparities. As per Sharkar et al., poor metrics lead to poor reimbursement and can lead to poor healthcare access and increase disparities. In conclusion, safety net hospitals that provide care to a large number of uninsured individuals need adjustment in quality care metrics that are achievable. Working to incorporate socioeconomic disparities into the metrics can lead to improved morbidity and mortality in rural populations. Thank you again for listening in. These are my references. I hope that you were able to take away some good information and have a better understanding of how pay for performance affects rural hospitals and populations. Thank you.